Voy a compartir la pantalla. Okay. Bueno, gracias por asistir. El día de hoy voy a presentar los resultados preliminares de mi tesis de doctorado, que trata sobre las experiencias de lactancia materna de mujeres profesionales de la salud en Ecuador. So to provide a little bit of background about the research, breastfeeding is socially and culturally constructed, and it goes beyond the biological act of feeding a baby. There are material, social, and structural determinants that might enable or constrain breastfeeding. And one of the most important factors is the health system. And although ample evidence exists that ratifies how essential breastfeeding is to guarantee the well-being for the mother and the baby, there is overall an ongoing inadequate approach to promoting breastfeeding practices in the public health arena. Consequently, worldwide, the breastfeeding rates are low, and Ecuador is not an exception, especially among working mothers. As a result, my study aimed to understand how do Ecuadorian women who have both identities as mothers and healthcare professionals experience breastfeeding and its repercussion for their practice as healthcare providers. Regarding the inquiry practices, the primary data for my study comes from synchronous semi-structured interviews and photo voice with Ecuadorian healthcare providers who are also mothers and who breastfeed their babies. The women of my study are currently working as physicians, nurses, and nutritionists, and they have experience in breastfeeding education at individual or group-based level in Ecuador. And using a snowball sampling, my study included 20 nurses, 20 doctors, and 20 nutritionists. The age of my participants ranged between 27 to 52 years. They have 1 to 4 children, and their breastfeeding period was from 2 months to 6 years. I employed a qualitative method called the constructivist Grandel theory to analyze and interpret my data. The central aspect of the constructivist Grandel theory is that knowing and learning are embedded in social life. As a result, both the data and the analysis are created and co-created with the participants, the researcher, and the data itself. The Grandel theory focuses on how, when, and to what extent the examined experience is anchored in a wider social system of a specific context. So the constructivist Grandel theory allowed me to understand how breastfeeding is constructed in the identities of these women as mothers and healthcare providers in Ecuador. So continuing with the inquiry practices and following the constructivist Grandel theory, I developed 4 cycles of coding. The primary cycle of coding was in vivo coding, which means that I use specific words or phrases that came from the actual language of my participants, that came from the interviews. And then the second cycle coding was focus coding, which means that I grouped my initial codings into patterns to start creating analytical sense. And then the third cycle of coding was actual coding. The actual coding allowed me to reassemble the fracture data and organize my data into categories and subcategories for analysis. And lastly, the hierarchical coding allow me to understand the process of how breastfeeding happens in this group of women. So it is important to mention that there is no formula of translating culture. Consequently, collecting our data in our native language and then translate it into English, this cross-language research is a difficult and complex aspect to unpack. As a result, I followed Gonzalez and Lincoln approach for cross-cultural and cross-language research. And according to the authors, the interviews and the first cycles of coding should be developed in Spanish. Because when we are talking the same language, the researcher and the participants, we can communicate and understand the social context from which the participants are coming and the words that they are using. And also the first cycle of coding in the constructivist Grandel theory is the first approximation to the data, and also this constant comparative method during the first cycles of coding allow me to compare one interview with another interview and also to compare the codes in the same interview. So it is important to continue developing it in Spanish in order to understand the context better. However, the last stages of coding, in my case, the actual coding and hierarchical coding, it is important to develop in English because English, in my case, was the main language in which I am going to present my final results. So the moment that you shift Spanish into English is essential to continue having the sense of what the participants were saying. Consequently, as a researcher, I decided to conduct the translation because I was familiar with the data. I am from Ecuador as well as my participants, and I am a healthcare professional as well as my participants. So I understand the context and the way that they were talking about breastfeeding. And in order to mitigate unwitting bias while analyzing and interpreting my data, I pursued member reflections through dialoguing with the mothers of the study about the interpretations of my findings. These are the main themes that emerge from the data. All of the photographs that you will see from these slides until the end are the photographs that my participants brought to the interview. And also in the next slides, you will see extracts from their narratives. And at some point when you will be reading these extracts, you might see that the English grammar structure might seem off, because I wanted to preserve the way that my participants were talking in Spanish. So the main themes, I will start with the decision to breastfeed. And this theme groups the reasons that these female healthcare professionals gave me for why they breastfeed their babies. So all of the participants in the study told me that the decision to breastfeed their infants was theirs. However, they all explained to me that their decision all arose from one or the other two main sets of influence. The first one was their profession, and the second one was the social expectations of good motherhood in Ecuador. So regarding the first aspect, which is the profession, all the participants during their training as doctors, nurses, and nutritionists learn and understand that breastfeeding is the best way of feeding a baby, and they wanted to give that to their children. And on the other hand, the social expectations was following a tradition in their families and in the social aspects in Ecuador, that the good mother is the one who provides the best to their children. So the best is breast milk in something that is internalized in my participants' mindset. So the social and biological representations of breastfeeding are based, as stated by my participants in the previous theme, on the idea that breast milk is the best way and the best food for a child in order to ensure their health. And also it's an activity that they were expected to carry out. Consequently, all the healthcare providers had that desire to breastfeed their children, and it was expected to perform from the beginning as soon as they gave birth until the end, until agreeing until having an agreement with their children. However, the majority of my participants, when experiencing breastfeeding for first time, was a challenge. Due to the dominant medicalized discourses of breastfeeding in the clinical realm, in which risk and milk insufficiency predominate. All my participants were mentioning the notion of risk after birth because the majority of the pediatricians and nurses during the delivery proposed to the mother that their child might be at risk. The baby might have hypoglycemia, so it's better to give him formula, or it's better for us to keep your baby in another room because it might be risky for him. And also the fact that a lot of my participants mentioned that the notion of milk insufficiency, several nurses and doctors were mentioning to my participants that they don't have enough milk at the beginning. So the medicalized discourse of breastfeeding shrinks maternal authority through restricting mothers from breastfeeding their babies as soon as they gave birth, or feeding the babies with formula without asking the mother's permission, or not allowing rooming in with their babies. Something that was very interesting is that very few healthcare professionals breastfeed their babies in the hospital for the first time. And all of them that had that privilege of doing that, it was because they had pro-breastfeeding gynecologist, or a pro-breastfeeding pediatrician, or a pro-breastfeeding nurse. So something that should be a right it's a privilege in the context of my study. And this theme explores, the next theme explores the way that my participants interrelated their identities as mothers and healthcare workers to reach exclusive and extended breastfeeding through accepting breastfeeding protective determinants such as support. So support was a critical factor that shaped their breastfeeding experience. For this group of women, the support came from two main instances. The first one was peer support, and the other one was their husband's support. Something very interesting was that the peer support was not related to other colleagues' support. It was related to expert mothers who knows how to breastfeed. So some of my participants, very few of them, had access to mother support group, such as La Leche League, or groups in Universidad Andina or Catholic University. So this group of women who have access to this mother-to-mother support group mentioned that they learn how to breastfeed, mentioned that they learn how to socialize with other mothers who are breastfeeding. And again, this was an aspect of privilege. Not all the healthcare providers in my study had access to these groups. And I asked them why, and then mentioned because they don't know that these groups exist, first of all, and also because of their demanding jobs. However, all of them had support from their partners. Their partners was the main support that they had during the entire breastfeeding. They provide emotional support. They were vigilant in the hospital because to avoid formula feeding. They were feeding the baby when the mother was not at home. And as at the end, several of my participants were mentioning that breastfeeding at some point was a teamwork for them. And although the participants had support from their mothers and mothers-in-law, especially after postpartum, there were a lot of controversials about it. First of all, because some breastfeeding traditional and cultural practices, such as the usage of herbal galactogos, like agua de Paraguay or colada de avena, are widely used in our country. All of my participants drank coladas. Several of my participants drank agua de Paraguay, although they are healthcare providers. And they mentioned that they did that because of their mother and mother-in-law comments and encouragement. However, in their professional practice, they diminish this kind of traditional practices in Ecuador. All of them mentioned, when I am with my participant, I never recommend this kind of beverages because I know that the stimuli is the responsible of milk production. However, when I have my baby, I tried those beverages. After their maternity leave, my participants had to come back to work. And breastfeeding for my participants was a negotiation process in their working environment. Very few healthcare professionals have access to lactation rooms, especially the ones who were working in academia or have their own professional practice. They had a more appropriate space to pump. However, the majority of my participants who were working in clinical settings, such as hospitals, healthcare spaces, clinics, they did not have the support from colleagues and bosses. All of them mentioned that they felt judged for being away from their duties. The majority of their colleagues were judging them because they were away from their duties and from their work. And all of those experiences brought them sadness and frustration. Continuing with breastfeeding working mother, reflecting on what my participants mentioned, we can understand how healthcare personnel who work at the hospital level and clinical settings are generally seen as an agent, non-gendered agent, who leaves their self-identity aside and completely turns to their profession, with their central role is to care and improve the health of their patients. As a result, when my participants incorporated their maternal identity and felt their breastfeeding body, their breastfeeding bodies were invisible at work. Why I'm saying that the breastfeeding body is invisible at work in this setting is because they did not have a lactation room. All of my participants who work in hospitals and clinics mentioned that the lactation room was only for patients, but not for healthcare personnel. Also, they did not have the time, and they have to go to storage rooms, they have to go to toilets, they have to go to their cars, they have to go to lunch rooms, they have to go to their office to express their milk. So the breastfeeding body in the clinical settings is invisible. So after experiencing breastfeeding, my participants create a new meaning of it. So they started to talk differently about breastfeeding, especially with their patients and their colleagues. So for the participants constructing breastfeeding as a unique bond, they mentioned that is something unique, is a gift of God, is liquid gold, goes beyond highlighting the benefits of breastfeeding for the infant's well-being and health. So these new ways of talking and discussing about breastfeeding rises after breastfeeding experiences firsthand. So all my participants mentioned that the incorporation, their maternal identity allowed them to improve their professional practice as nurses, nutritionists, and physicians. They became more empathic and started to listen to more to their patients without judging their decision. Some of my participants became also breastfeeding advocates in several spaces, such as academia. They created mother-to-mother support groups, virtual and in person. And they started to reinforce the knowledge about breastfeeding with other colleagues. And just to conclude, although these women believe that breast milk and breastfeeding is the best way to feed a baby, these women, when experiencing breastfeeding, shifted the preconceived idea of ideal breastfeeding that came from the medicalized and positivist discourse constructed in their training as healthcare professionals. And although they had this clash between the idealization and the reality, they continue breastfeeding their babies. And those experiences made them to improve their professional practice. Experiencing breastfeeding in this group of women in the Ecuadorian context was relationally and vocationally expansive. They often indicated that breastfeeding influenced their ability to participate more fully in their careers and enhance their capacities to perform their duties, to communicate better with their patients, and to become more empathic. Overall, this study highlights that breastfeeding for this group of women appears to be a unique relational and identity negotiation process. These are the references that I use for this presentation, and thank you for your attention.
Muchas gracias, Majo. Excelente. Queremos dar la palabra, por favor, a preguntas.
Can I?
Yes.
Yeah. Majo, you know that I'm a big fan of your studies, so I have two questions. One of them is, what challenge do you face when you collect the information in your language and then you had to translate it into English?
I think that the main challenge was to trying to keep as accurate as possible the way that my participants were expressing breastfeeding. Because, for example, in our culture, my participants were mentioning words such as la lechecita para mi bebé, or mi banco de leche, and words that maybe in English are not like they don't have the same meaning. So that was the main challenge for me.
Yeah, and the last one. As you know, I'm much into a quantitative approach. And why is qualitative research important in breastfeeding studies?
I believe that there are a lot of research about breastfeeding. We know that Ecuador has low breastfeeding rates. We know that healthcare providers at hospital and clinical level, they don't accomplish the skin-to-skin contact. They don't allow the mothers to breastfeed during the first hours of birth. So we already know that, but with qualitative research, we can understand what is happening in certain group of people. In this case, I chose healthcare professionals because at some point we believe that healthcare professionals, especially doctors, knows how to breastfeed, and they will have a very perfect and ideal breastfeeding experience. But it was totally the opposite. The healthcare providers were a risky group for breastfeeding because it was challenging for them, because although they wanted and they know that is important, there were a lot of constraints in their work to perform that, especially at hospital level. So the qualitative research allow us to understand more in depth the realities of women who breastfeed. And of course, there are a lot of future research to develop about this with other women in different settings. Because if we see that healthcare providers, women who have studied, who have support from their husbands, who have knowledge faces so many challenges. Can you imagine women who don't have all the privilege that have my participants?
Thank you, Majo.
Thank you.
¿Alguna otra pregunta? Sí. Daniela, por favor.
Gracias. Majo, felicitaciones. I'm so happy to see you and just to hear that you have ended with your thesis, and I really hope to see you soon. So I have one question. Which one do you think is the main factor for professionals to support their breastfeeding practices?
The main factor to support their breastfeeding practice, I think, is their knowledge. Their knowledge was essential because they know that breastfeeding was essential for their children. And although they struggled a lot, they continue breastfeeding. And also the support that came in this case from their husbands, but especially from other women. It was very interesting that the ones that had access to female and groups and mother-to-mother support groups have a better experience than the ones who doesn't.
And just another one. How does experience change your point of view about breastfeeding practices?
As I mentioned at the beginning, the researcher in qualitative studies is part of the study. And for me was very, very, it shifted a lot of my beliefs as well. Because as a healthcare professional, I'm a nutritionist, and when my participants were talking, I was remembering when, for example, I was in my practice in Ecuador, and we were with the mothers, and we were like, but you should breastfeed, and you have to breastfeed, and it's the best for your baby. But when I was listening to the mothers and understanding the realities that they're faced, allowed me to shift several paradigms that I had in my mind, especially regarding bottle feeding, because some women mentioned, yes, I mean, I express my milk, but I have to use a bottle. For me, was not an option to use a cup or to use a cucharita. I can't. I just have to feed my baby. So they shifted a lot of dominant discourses that we have in the public health realm about breastfeeding that sometimes are very normative, and we don't focus on the social aspect of it.
Thank you, Majo, and congratulations.
Thank you, Dani.
Si no hay más preguntas, igualmente, Majo, felicitaciones. Yo espero no perderme tu presentación de tu tesis y te deseo muchísimos éxitos y esperemos que regreses pronto con nosotros al Ecuador. Y la verdad que es un gusto escucharte y pienso que todo va a salir muy bien. Mucha suerte con tu tesis.
Muchas gracias, Lien, y gracias a todos por estar hoy. Que tengan una buena tarde.
Gracias. Queda grabada, luego les comparto el enlace para que lo mantengan y los que no pudieron asistir, si quieren escuchar, puedan compartir.
Gracias.
Gracias.